So insulin resistance usually occurs in people who have gained weight since they stopped growing. If you were aware that now I have insulin resistance and I want to do something about it, the best way is to get yourself on a diet that you can successfully lose that excess body fat, because ultimately it's the excess body fat that is deposited in the liver and deposited in the pancreas, which causes the two main problems that lead to prediabetes and type 2 diabetes. You could have normal blood sugars on your continuous glucose monitor for 10, 15 years, but yet all that time you had an elevated insulin level. It is just your pancreas was able to make enough insulin to compensate for the insulin resistance problem. What we know is there's 3 tissues in the body, 3 main tissues that become resistant to insulin that results in the manifestations of insulin resistance. And those 3 tissues are the liver, the muscles, and the adipose cells, or the fat cell. If a doctor is taking care of a patient and never measures an insulin level, then they may have insulin resistance but not know about it. And that's where this idea of the metabolic syndrome comes in, because that is a syndrome of 5 different characteristics, which might give you an indication that maybe you do have insulin resistance, because insulin resistance is the cause of the metabolic syndrome. And so the metabolic syndrome, the 5 components are...
I like to ask this question primarily because I tend to get different answers depending on the expert I'm talking to. So for you today, can I ask you this question? What do you think is driving this epidemic of chronic metabolic disease that we're seeing across the world at the moment?
Yeah, that's a great question. I honestly, I've been thinking about that for the past 10 years. And I think the reason that the experts who do research in this field have varying opinions is because none of them actually know what the cause is. I suspect that there's probably a variety of things going on at the same time, and they're clearly all environmental. But I think I can list off some things that I think are important. For instance, back in the 1950s, we really started on this processed food diet, which we're now calling it ultra processed. But it really started back in the 1950s, before I was even born. And so that means that the parents of the baby boomers were being exposed to this food. And then when a woman is pregnant and is on a diet that affects their metabolism, then there are epigenetic effects on their offspring. And then those offspring are, raised on that, let's call it ultra-processed food diet. And then with each passing generation, I think that the effect of that ultra-processed food diet gets worse. There are also chemicals in the environment. They're called obesogens, which are probably contributing some component to. And I don't think the exercise aspect of it is a big contributor. They've kind of looked at that, and it doesn't seem like we're as sedentary as some people suggest that we are compared to many years ago. But of all these factors, though, I think it's this ultra-processed diet. And the components, there's a number of components of it, too. So there is increased amount of sugar in ultra-processed foods. There's refined carbohydrates, particularly grains. And the grains that's an important issue because, for instance, in the United States, I think our grains are fundamentally different than those that you have in your area of the world. And those changes in the genetics of the wheat make the gluten different. And I think that there's a lot of people who have adverse reactions to gluten, which leads to leaky gut and acquisition of autoimmune diseases. So I think that's a factor. And then there is the trans fats, which, were officially removed from the diet, but I think on a realistic basis, they really haven't been removed in the United States. All they did was they reformulated some of their products to contain fewer trans fats, and they were able to report zero trans fats in their food if they had less than a half a gram of trans fats per serving. And then the food industry got to determine what the serving size was. So they could lower it a bit, reduce the serving size, and still report their food as having zero trans fats, even though it had trans fats in it. And these processed vegetable oils or seed oils, whichever term you like, they contain trans fatty acids. Anywhere from, I saw one publication where they analyzed a whole variety of vegetable oils on the, in a regular grocery store shelf, and found anywhere from 0.5% of the fat being trans fats up to 4.5% being trans fats. So if you're eating foods that are, say, deep fried in vegetable oils, 1/4 of all the calories of French fries, for instance, comes from the vegetable oil that's absorbed into the potato. So people are eating quite a bit of vegetable oil, even if they're not aware that they're doing so. And then, subsequently they're getting quite a bit of trans fats that way. So those are kind of a number of the characteristics of ultra-processed foods. And then there's a few more that I just want to briefly mention. One are emulsifiers. There are probably 8 or 10 substances added to foods called emulsifiers. And what that does is it prevents separation of water from fat. So that, when you make a processed food, you want that product to be uniform each and every time. You don't want to open it up and then, see, there's a layer of oil floating on the top of my food. So by adding the emulsifiers, the food is intact as it was the day it was put in the package. But the problem is emulsifiers do the same thing as gluten. They open up junctions between the intestinal cells and allow foreign proteins to enter the bloodstream, and that can lead to autoimmune diseases. So emulsifiers, I think, are a problem. And then probably a more minor effect is there's preservatives and colorings and flavorings. The problem with flavorings is it makes the food more desirable to eat. And then people will tend to eat more than they intended to eat, simply because the food tastes so good. So I think this ultra-processed food, which, fortunately it's being talked about a lot now. So I think that's a good thing. If people can figure out that might be a major source of the problems they're having, and try to reduce the frequency that they utilize those foods, that might help.
Well, this is what I wanted to talk to you about next, because you're talking about awareness, and I have spoken with other people on this podcast about accessing information and education, and you have listed off a myriad of different ingredients there and chemicals and various exogenous chemicals that are placed into food. And I use the word food in inverted commas because most of this isn't food. It's a highly processed with ingredients.
I like Michael Pollan's phrase. He called it food-like substances.
Sure.
Well, I think that's where podcasts like yours are very, very valuable. I think people just need to use the internet to find a source of information that they feel is reliable and trustworthy. And then, the neat thing about diet is you can change what you eat. And if you get the results you're looking for, then you continue doing that and, make iterations on that. And if it doesn't work, then it doesn't work. It doesn't matter what sort of scientific study is published. If it doesn't work for you, then it doesn't work for you. So I think that combination of seeking out information on the internet and trying to make a judgment as to whether you think that's a reliable source, and then try what is suggested. And if it works, fine. If it doesn't, well, keep searching for more information.
Now, I know you're a type 1 diabetic condition you've been managing for well over a decade now, possibly two. Can I ask you how your own condition informs your interaction and your appreciation of food on a day-to-day basis?
Yeah. Well, unfortunately, I was diagnosed in 1998. And so, I was just beginning. I think I was using the internet with a dial-up connection back then. And of course, I didn't even think about looking into diabetes management on the internet because, I was a board certified internal medicine physician at the time. I thought I knew how to treat diabetes. So it took me 14 years to stumble across the diet that I am currently using to manage my diabetes. And that diet is a low carbohydrate ketogenic diet. But the way I found out about it was actually through a sports podcast because I was training for the Ironman at the time. And they had interviewed Lauren Cordain, who developed the paleo diet. So, but what Dr. Cordain really opened my eyes about the influence of diet on health. Because as you probably know, we are in medical school, we're not taught about diet in terms of its effect on diseases. The only education we had was about these deficiency diseases, from 100 years earlier, which no longer exist. And I was kind of confused as to why they were telling us about it. I didn't really find that it was going to be very applicable to my practice since nobody has pellagra or Wernicke's or anything anymore. But so with that lack of education, I was really surprised to find out that the food that you do eat really does have an influence on what diseases you'll either get in the future or that you could change your diet and affect the diseases that you currently have. And so I started on the paleo diet and then continued my research and kind of like what I described before. And I started on the diet. I had some improvements, but not dramatic. And then when I came across the low carb diet, then I noticed a dramatic improvement in my blood sugars. And I can explain to you why I think it was such a difference, if you like.
Please do, yeah.
Okay. So it turns out that if you take normal, healthy subjects and you give them various test meals, and then you measure their blood sugar and their insulin levels after you administer the test food, it turns out that carbohydrates require the most insulin to be secreted from the pancreas compared to protein and fat. So if you measure how much is due to protein, it's actually about half as much insulin as carbohydrates. And if you measure how much insulin is needed to digest fat, it's about 1/10 as much as carbohydrates. So that kind of is the basis for why a very low carb diet, which reduces those carbohydrates as low as you can manage on a long-term basis, why that reduces the amount of insulin that a person with type 1 diabetes needs to inject each day. And that in turn has other benefits. So first of all, having lower insulin actually has a direct effect on the development of various diseases. So it's known that having higher insulin levels in the blood promotes atherosclerosis. That's been found both experimentally and through these observational studies in humans. Also, we know that, for instance, Alzheimer's disease occurs more frequently in people with type 2 diabetes. And the difference between type 1, or one of the differences between type 1 diabetes and type 2 diabetes is that persons with type 2 diabetes have elevated insulin levels in their blood all the time. And so with Alzheimer's, they develop insulin resistance of the brain, and that impairs their ability to utilize glucose to certain portions of the brain cells that relate to memory. And so this, initially it's like a functional impairment, which if you were to start on a ketogenic low carb diet and then provide your brain with ketones, and we can talk about how all that works too. But if you provide your brain with ketones when they're in a state of being unable to use glucose as well, then they can have rapid improvements in their memory, because now they have a source of fuel which they like, which is now available to them that wasn't available when the person was consuming a lot of carbohydrates and had no ketones in their blood. So that's one example of where high insulin leads to, let's say, atherosclerosis and Alzheimer's, but there are a number of other diseases too. So lowering in a type 1 person now, lowering the insulin that we need also reduces the frequency and severity of low blood sugar episodes. We call them hypoglycemic episodes. That is actually, from a personal point of view, one of the worst things about having type 1 diabetes, because those episodes just feel horrible. You know, if you're in a group of people, it's very embarrassing because your behavior can change, and the hypoglycemia often happens so quickly that you're not even aware that it's happening to you. And it's dangerous. You know, there are some patients who die from hypoglycemia. Usually it's in their sleep because they're not aware that it's happened. And then the third major benefit of a low carb diet is the fluctuation in blood sugars is much reduced. So you stop having those very high blood sugars, which you have to then treat with extra insulin. And then oftentimes that extra insulin, sometimes it'll bring it down to normal, but other times it'll bring it all the way down into hypoglycemia. So by not having the highs, you also reduce the lows. And by having normal blood sugars, then you don't develop the complications of diabetes, including blindness from retinopathy, kidney failure from nephropathy, and numbness in the legs and loss of limbs through the neuropathy that happens from diabetes. So those are kind of a summary of the major benefits of a ketogenic diet for type 1 diabetes.
Which metric or biomarker is more significant across diabetes 1 and diabetes type 2? Is it glucose or is it insulin?
Well, honestly, I'd say they're both equally important. So And also, I should mention that even though type 1 diabetes and type 2 diabetes both have the word diabetes, they really are quite different diseases, and they should be thought of as very different. Um, only about 5 or 10% of people with diabetes have type 1. So it doesn't get talked about a whole lot. So when people will hear the word diabetes, the person's usually talking about type 2 diabetes, which is not what we were just got through talking about. And that's, I don't know if you want to talk about that today or not, but it's kind of a different ball of wax. But as I said before, in type 2 diabetes, the blood sugars are elevated and the insulin is elevated all the time. And both of those are leading to the complications. It's thought that the elevated insulin in type 2 diabetes is in large part responsible for the atherosclerosis, which leads to heart attack and stroke and peripheral vascular disease, which is the main culprit, whereas the high glucose is what leads to the blindness and the amputations and the kidney failure needing dialysis and transplantation. So both are equally bad, I say.
You mentioned the term insulin resistance. This is a term that's come up again and again in discussions that I've had about diabetes. Is insulin resistance, just for the audience, is it common to both types of diabetes, type 1 and type 2? And could you just clarify again exactly what insulin resistance is? Because my understanding is that the body becomes almost numbed to the glucose that comes into the system, and that it basically the insulin levels just rise up and continue to rise. Would that be correct?
Yeah, that's a good summary of it. The details are involved, and I've been studying insulin resistance for about 10 years also, and it's not that simple. What we know is there are 3 tissues in the body, 3 main tissues that become resistant to insulin that results in the manifestations of insulin resistance. And those 3 tissues are the liver, the muscles, and the adipose cells or the fat cells. And there are arguments about which one becomes resistant first. So I don't think I can resolve that issue today. But those are the 3 main organs that become resistant, and each one, that resistance has different effects. So, for instance, the muscles are a very good sink for glucose. So if you have a little bit of an elevation of glucose, it's mainly the muscles that take up that extra glucose and either burn it or store it as muscle glycogen. So if you have insulin resistance of the muscles, well, they're less able then to take up any extra glucose in the bloodstream. Same thing with the adipose cells. Adipose cells will take glucose in the bloodstream, take it into their cells, and then convert it into fat. It's called de novo lipogenesis. So and they're typically the last of the 3 to become insulin resistant, although again, there's arguments about that. So if fat cells become insulin resistant, then they're less able to take up glucose. And then the liver takes up glucose and it will convert it to glycogen, and it can store that glycogen to remove it from the bloodstream. But when the liver is also responsible for making glucose and putting glucose out into the bloodstream. And it does that around the clock. And there are hormones, mainly insulin and glucagon, that tell the liver how much to make and how much to release or how much to store. And so when the liver becomes insulin resistant, it will tend to continue to produce glucose even in situations when it shouldn't. So for instance, after you eat a meal, the increase in insulin made by the beta cells goes directly over to the liver, and tells the liver, don't make glucose right now because we have enough glucose coming in from the meal. And so it puts the brakes on the liver. But in the setting of insulin resistance, it doesn't really see the insulin as well. And so it keeps producing the glucose. So that's what results in a very high blood glucose after a meal. It's not only what was in the meal, but it's that lack of communication to the liver, which continues to make glucose when it shouldn't.
And so as the glucose levels are constantly rising, and this is characterized then by the insulin resistance, are we seeing a commensurate rise in insulin in the body? So is the insulin level high as well as the glucose level high over a chronic period of time?
Because the insulin resistance results in a compensatory mechanism by the beta cells in the pancreas to try, they somehow get the signal that there is this insulin resistance. And so they try to compensate for it by making more insulin. But what's interesting to know, though, is that this insulin resistance precedes the development of either prediabetes or type 2 diabetes by, 10, 15 years. So people can be insulin resistant and have elevated insulin levels as a result of the insulin resistance, yet they're able to produce enough insulin to equally compensate the insulin resistance such that their blood sugar doesn't rise. If a doctor is taking care of a patient and never measures an insulin level, then they may have insulin resistance, but not know about it. And that's where this idea of the metabolic syndrome comes in, because that is a syndrome of 5 different characteristics, which might give you an indication that maybe you do have insulin resistance, because insulin resistance is the cause of the metabolic syndrome. And so the metabolic syndrome, the 5 components are, one is elevation of blood glucose. Now that's the one you would know about, but the other 4 you might have, but not know that it's connected to insulin resistance. And the other 4 are, one is elevation of blood pressure, elevation of triglycerides in the blood, that's a blood test, reduction of HDL cholesterol in the blood, and the other one is an increase in your waist circumference. And what that indicates is that you're depositing visceral adipose tissue, meaning around the organs and around the intestines, and or you're depositing fat in the liver and the pancreas. So depositing fat in organs and around the viscera is not normal, and that results in this insulin resistance. So those are the factors that if you have those, you should sort of be wondering, well, do I have insulin resistance? And it's really important to start addressing that sooner than later, because you can develop these chronic diseases related to insulin resistance even before you're diagnosed with prediabetes or type 2 diabetes. So again, you could have a heart attack as your first sign that you've had insulin resistance for 15 years. Or you could have a stroke. That's your first sign of insulin resistance. Or you could develop cancer. That's the first sign that you have insulin resistance. And so think about, you would like to avoid those problems. And if you were aware that you had insulin resistance 15 years earlier and had addressed it then, you might have saved yourself a lot of misery.
Again, I always love to talk about biomarkers. Should we be having our insulin levels checked then? Because today it seems everybody, including myself, I've an interest in these continuous glucose monitors, but that's only part of the picture by what you're painting there.
That's right. Yeah. So, like I said, you could have normal blood sugars on your continuous glucose monitor for 10, 15 years, but yet all that time you had elevated insulin levels. And it's just your pancreas was able to make enough insulin to compensate for the insulin resistance problem. So, yes, I agree that I think insulin levels should be part of routine screening for metabolic problems in a doctor's office. It is currently not.
Yeah, no, that's the case, and other doctors I've spoken to have said the same thing, and have been just as critical, because all of the focus seems to be on glucose, and there's very little focus on the insulin and the ramifications of long-term insulin resistance, which you've just painted the picture of there. How then is it possible, if we can just stick with, if you don't mind for the moment, if we can just stick with prediabetes and with diabetes type 2, how is it possible to reverse insulin resistance then through dietary measures and or behavioral measures or changes in somebody's life?
So insulin resistance usually occurs in people who have gained weight since they stopped growing. All right. So let's say that the trouble with what I'm going to say doesn't really apply to what we have going on today in many cases, where children actually are either born with excessive body fat, or they develop it as a child or as a teenager. But what I'm going to describe is mainly like when I grew up, there were hardly anybody who was overweight all the way through the end of high school. That was pretty unusual. So let me just address that scenario first. So let's say that when you graduated from high school, you pretty much stopped growing, and you were at a normal body weight. Now, let's say you gained 10 kilograms over the next 10, 15 years, maybe 15 kilograms over the next 20 years. Then there's a good chance that that was enough extra body fat to make you insulin resistant. And depending on what your body structure is like, your BMI, which is body mass index, may or may not be in the overweight category. But even if you're not technically overweight by that BMI measure, you could still have insulin resistance due to the extra body fat that you'd put on since you were aged 18. And so in that situation, if you were aware that now I have insulin resistance and I want to do something about it, the best way is to get yourself on a diet that you can successfully lose that excess body fat. Because ultimately, it's the excess body fat that is deposited in the liver and deposited in the pancreas, which causes the two main problems that lead to prediabetes and type 2 diabetes. Is the fat in the liver is what's leading to that insulin resistance, and the fat in the pancreas is impairing the pancreas's ability to make insulin. So that double combination is what's going to eventually lead to prediabetes or type 2 diabetes. So by losing that excess body fat, the first fat to leave is the fat in the liver, and then the pancreas fat will leave too, but it takes a little bit longer in terms of months, not years. But anyway, to get that 15 kilograms is a term, and I can tell you how I came up with that number. But 15 kilograms, if you lose that much weight, you can pretty much be assured that your insulin resistance will be gone and that you won't subsequently develop prediabetes or type 2 diabetes. And the same thing for people with diabetes. If they lose that much weight, then they won't be pre-diabetic. And same thing for type 2 diabetes. If they lose that much weight, they probably won't have type 2 diabetes either. Now, in terms of how do you lose that weight? Well, I think that really depends on the person. Um, I have known patients who were just able to cut back on the portion size, and they were able to do that. Others seemed like they needed a more strict type of intervention. You know, some would count calories. Most people don't like to do that, but it works for some people. Other people need more specific things, or, you know, by limiting certain foods. So, like in the case of a low carb diet, you will emphasize limiting foods that are high in carbohydrates. Some people are successful with a low fat diet, although I would say that's the least successful group, but by limiting the amount of fat in the diet. And, you know, people react to limiting things differently. So, for instance, I noticed that people who try to restrict their fat tend to be hungrier more than people who restrict their carbohydrates. So, if you are, you know, these diets are not meant to be something you're going to do for a few months and then you go back to doing what you're doing before. That just won't work, because you'll wind up where you were before. So you have to pick some kind of dietary strategy that you can do for the rest of your life. And if you're hungry doing your dietary strategy, you're not going to do that for the rest of your life. So that's why you have to pick something that you feel satisfied with, that you can do for the rest of your life. Because, well, I said it. I mean, if you don't stick to it, you will wind up where you were before.
It's such a common sense approach. It really is. I think it's a very balanced approach, and it makes complete sense. You have a great blog. I will stick a link to that in the show notes for this episode. Can we go back to your own situation? You're a type 1 diabetic. Yeah. I'm interested to hear the approach that you take, because you have a suite of different things that you do in order to manage your condition, everything from medicines to your diet. And I know you're very physically active. You mentioned triathlon earlier. Could you talk to me about what your own diet looks like, just logistically, what it's made up of? And as I said, I know you're on a couple of medications as well, because you are a type 1 diabetic, so you have to have that medication.
Yeah. So my ketogenic diet, I've been on it. I should have mentioned I started on this in February 8th of 2012. And I'm the kind of person, I would say, compulsive maybe. I've actually never cheated on this diet for 12 years. So, and I think that's pretty unusual, having talked to a lot of people who try to do various diets. I'll give you that caveat. But anyway, so I basically started with kind of the traditional Atkins diet. And basically what they do is they emphasize eating a limited amount of green vegetables that, you know, you call them non-starchy. So, you know, be like broccoli, cabbage, spinach, that sort of thing, where you can, you know, I think what vegetables kind of do is it gives you a sense of fullness, you know, kind of takes up space in your stomach. You know, I'm plus or minus on the effects of fiber. I'm not really sure what fiber does. A lot of people think it helps your microbiome, but I'm not quite sure. There are a few vitamins in vegetables, so, you know, they may have some benefit. But it's limited, though. If you eat tons and tons of vegetables, the carbs will eventually add up. And then for me, I've chosen mainly animal foods. So I like beef, eggs, salmon, and I like dairy. So I like cheese, but it's got to be hard cheese, because when cheese is fermented, the microorganisms that they add to the cheese consume the lactose, which is the sugar in milk. So by having it aged, the cheese aged, you're basically getting rid of the carbohydrate. So it's aged cheese. those four things. Yeah. And then I make a little dessert so I don't feel like I'm just on a very limited, deprived diet. And so I use completely 100% chocolate. It's got zero sugar in it. It's called the uh, unsweetened chocolate, I guess they call it. So to give it just enough sweetness to um, cut that bitter taste, I add allulose, which is a natural sugar that's in a few fruits, but now it's synthesized from corn. Anyway, so I use some allulose, and then I mix that in with some peanut butter and some cream cheese, and then I put some butter in it, and sometimes some coconut oil or MCT oil. And basically, I'm adding those fats just so that I can get my enough calories to fuel my body and fuel my exercise. But I'm not trying to eat, gobs and gobs of fat. It's just so that I get enough calories. And I'm not trying to get high ketones by eating more fat or anything like that. It's just to get the number of calories I need. And for me, I'm 71.5 kilograms. I'm 64 years old. I'm 5'8". So that's about 2,000 calories a day. It seems like kind of a low number because when you go in and you use these equations to estimate your caloric requirements, for my size and age and activity level, they say I should be having about 2,500 calories. But I just basically add fat to my body when I eat that much. So I've kind of worked it out to about 2,000 calories a day. And that seems to work for me.
And how much, by the way, of carbohydrates would you be consuming per day?
Yeah. So right now it's about 23 grams a day total carbohydrates. Yeah, it's pretty low.
Yeah, it's pretty.
I didn't start like that. I didn't start like that because I have refined this over time. So to be on a ketogenic diet, it's 50 grams per day or less for the total. And I've gone higher than that, especially when I was doing the Ironman training. But over the years, I really have come to realize that the body can exercise just fine without carbohydrates. I don't know if you've interviewed Tim Noak, but he would be great to have on the podcast because he's actually done the research that demonstrates that people who are endurance athletes, as well as people doing more intense exercise, for instance, running 800-meter sprints, they can do that with no impairment, just on fat. So this part about exercise science where any kind of intense activity requires carbohydrates, I really don't think that's true anymore. I think the research that led to those conclusions was biased by the fact that the funding for all that research was by companies like Gatorade and Coca-Cola and that sort of thing. And I suspect it probably was subconscious, but I suspect that they wanted to find a positive benefit from consuming carbohydrates during and after and before exercise. But I'm not a professional elite athlete, of course, but I have found no difference in my ability to exercise before and after starting this diet. So I don't think you really need carbohydrates to exercise.
And tell me then, what impact has this very low carbohydrate ketogenic diet had on your condition and on the amount of medicine and insulin that you would need to inject with in comparison with somebody who wouldn't be as rigid about their diet as you have been as a type 1 diabetic?
Yeah, I'm glad you asked that because I forgot to mention it. So before I started, I was taking 58 units of insulin per day. So that's if you take the basal insulin, which is a once a day injection, combined with, say, for 3 meals, it'd be 3 separate injections of bolus insulin. You add all that up, 58 units a day. Within 2 weeks of starting this ketogenic diet, I was down to 28 units a day. That's in just 2 weeks. So it was a very rapid reduction in my insulin requirements. And as I say, I've kind of trimmed down the amount of carbohydrates over the years. So now I'm on about 22 units of insulin a day. And there have actually been studies where they take normal people without diabetes and they feed them a quote normal diet, which, means 50 to 55% of their calories coming from carbohydrates. And then they measure how much insulin the pancreas made in 24 hours. It comes out to about 45 units a day. So what that means is I require less insulin than a normal person without diabetes while they consume a high carbohydrate diet and I consume a ketogenic diet. So to me, I think that's a big benefit, that I'm not exposing myself to insulin day after day, month after month, year after year, that I don't have to be exposed to, which I think will reduce my chance of getting various chronic diseases that we've talked about.
This is what I'm so interested in. And I've spoken to a lot of experts in this area, and I'm really interested in this approach, this dietary approach, and this behavioral approach that people can take to managing such a serious condition. Because type 1 diabetes is a serious condition. And I love the fact that you have seen so many benefits over the long term. Very often when we hear about diets, these are basically referred to as fads. They're short-term things that people look for a short-term quick fix solution. But the fact that 1, you're a medical doctor, 2, you're a medical doctor with type 1 diabetes, and 3, you're a type 1 diabetic medical doctor who has ascribed to this particular approach for well over a decade now and can see the benefits of it, for me is a vote of confidence in this particular approach as far as I'm concerned.
Yeah, I think I totally agree, obviously. But, I keep hearing these articles written by journalists in various magazines and newspapers and stuff, who you can tell in the first few sentences that they want to try to badmouth a ketogenic diet. And invariably, they will talk about how it's not sustainable. And that kind of offends me, because I think if they were facing a serious disease and there was such a simple solution, which is simply to change the types of foods you're eating, which make you feel satisfied, gives you the energy, prevents you from feeling ill or developing illnesses in the future, how can they say that it's not sustainable? It really boggles my mind, because it's somebody who can take such a serious condition and make it better. It seems like a no-brainer to be able to follow a ketogenic diet.
Well, words of wisdom there from personal experience, and plenty of words of wisdom in both of your books. Master Type 1 Diabetes, the simple low-cost method to normalize blood sugars. And you've also written Conquer Type 2 Diabetes with a Ketogenic Diet. And I'll pop a link to those books in the show notes of this episode. Before I let you go, Doctor, can you give me your website and where can people get access to your blog?
Yeah, it's ketogenic-diabetic-athlete.wordpress.com.
And again, I'll pop a link to that in the show notes. It's been so interesting talking to you and hearing about your personal experience and your professional expertise on this subject. Dr. Keith Runyan, thank you so much for your time.
Well, thank you. I appreciate you having me on your show and being able to tell people about this condition that they don't get to hear about in very many places.
Well, thank you for tuning into this episode of the Happy Habit Podcast. If you enjoyed it or any of the previous videos, show your support. It's free. You can like, subscribe, and tell other people about this podcast series. In the meantime, check out this other video right here. And until next time, stay happy.